We will move on to the last talk for the session, which is on premium IOLs post-refractive surgery, when, why, and how. Yeah, yeah, just 5 more minutes. Don't worry. It's okay. Yes, no problem. I'll do that. Thank you.
I'll finish, don't worry. So, I think everyone who has undergone LASIK surgery will want to have this because they are doing premium. Okay. So if that is there, then it's going on. So people who undergone and spend so much money for LASIK, an example, will want to do this. So how in the OT? I think in the OT we should have digital image guided surgery. We have to do flax, and of course the paperwork is very, very important because patients. So in the OT, what is important here to understand is that don't make a mistake in seeing the paperwork. So that's important. As far as the OT is concerned, I think look at image guided surgery. You can see that I have done marking with ink and I've got Virion, which is digital imaging. So this proves that yes, both are equally accurate and this can go on quite well. So really nothing much to worry, but this can happen. So I think image guided procedures like Callisto or Virion, no financial interest anywhere, will give better results as far as it's concerned. As far as flax is concerned, in the operation theater, you can see that I'm making an incision with the help of a keratome, but the image guided procedure is helping me to make sure that the incision is very accurately placed. So I know my SIA, I know exactly how to place the incision, so that is helping me. Then coming to the next part of it is look at the CCC. It's very well centered on the visual axis. Here, some big advantage here is that goes around, and this causes a completely free floating CCC, which you can see here, and this will center the IOL extremely well. So this is one additional benefit that we get as far as the whole procedure is concerned. Then coming to calculations. So post-refractive calculations are very important. I'm now using Anterion. It combines corneal analysis. It does anterior chamber depth, lens thickness, and actual length measurement. Gives the density of the nucleus at the same time. So you come to know. Another most important step is that the spike that is coming from the retina is also well evaluated, and acquisition quality is also summarized. So you get multiple green ticks, which also help. Here you get information from the anterior surface, posterior surface, pachymetry, total cornea, and the refractive index. So the total cornea is the most important information that we are getting. Total corneal power especially is necessary for formulas like Barrett. And of course, the total corneal power for toric IOL calculation is also very, very important. So as far as the information that we are getting from the anterior is actual length measurement, keratometry, steep cornea, total corneal wavefront. So if you have an aberrometry which shows that high order aberrations are much higher, then you may want to avoid using a multifocal IOL, etc. So that again information you get in one shot. Depth of the anterior chamber, white to white, and pupil center and angle kappa. So all this information you're getting, all this information is necessary in post-refractive cases. Any error somewhere is going to make a patient unhappy. Here again, IOL calculations, big advantage that you have both the eyes together. So if you have a big disparity between two eyes, it will really happen and you will see a difference between the two eyes. So you can see IOL calculation compared in a single view. One thing, corneal data, anterior actual measurement, angle kappa, all of this data is measured and shown in one case. I'm just showing one case. 55-year-old post-myopic LASIK nuclear sclerosis grade. I wanted to plan a multifocal IOL. Here you can see that it's a long eye. ACD is information that you're getting, lens thickness you're getting, that will tell you your expected lens position. And of course, keratometry and white to white. So all this will happen at the same time. Now IOL calculations that are there, which is there, you can see the IOL calculations. The calculation comes from all different formats. Uh, I use all the different formulas that are necessary, and I'll tell you a difference. So I use Barrett True K. Of course, we also use Hill RBF and get the information. So here we are getting information from the ACRS calculation, ACRS anterior calculation, and IOL master. And you can see that all the IOLs that we are really using is around the same, and I went ahead and did this calculation to get 22 diopter IOL. And you can see the post-op result is that the patient underwent an uneventful trifocal implantation with a 22 diopter in the right eye, and on the fifth day the patient was 6 by 6 part N6. Autoref of course has no value. So here is one more case that I'm showing, that you can see a beautiful round femtorexis. So post-refractive patients are very, very demanding patients because they've had spectacle free vision for a number of years. So multiple things will help you to get sure that your results are very, very good. Here you can see a nice round femtorexis, which is right well centered. And once the lens is in the bag, big benefit I see is that the lens automatically centers in the bag. You don't have to really worry about it at all. And then another important thing is remove the viscoelastic from in front of the IOL, and also remember to remove the viscoelastic from behind the IOL. So that's one another big benefit that you can see here, that it's gone and the viscoelastic is completely removed. Now here, one more thing I want to show you is that I'm not using keratoderm. Now I make incisions, my side port, everything with the help of flax. And you can see the important thing, only I'll take 1 minute more, that this is the incision at 160. Half the incision is on this side of 160 and half the incision is on the other side of 160. So we can get that kind of accuracy with flax. And it's a biplanar incision, so it's extremely self-sealing. You'll also notice that I've made the main incision, put in the viscoelastic, and I've also made the side port with the help of the laser. So I'm really not using any MVR blade. You can see that I'm just using an instrument like a Sinskey hook, and that itself opens up the incision. So these incisions are extremely self-sealing. You don't have to worry about leak at all. Go ahead and do your phacoemulsification. Once the phacoemulsification is done, do the bimanual IA. Once the bimanual IA is done, we go ahead and implant the lens in the bag, and these patients do extremely well. So I feel toricity marking, which comes from any of the devices, either you have image guided, all of this will make sure that your results are very, very good till the end of the procedure. So here you can see that the lens placement is at 173. Now this is only possible when you do it at 173. Otherwise, manual marking will cause some errors. Otherwise, you'll have no issue. Thank you for your attention.